Okay, now you've decided that your pediatric patient has either TB or LTBI. How do you go about treating him or her? Your first step is to determine the local requirements for reporting cases to the local health department, or LHD. All 50 states require reporting suspected cases of TB to the LHD within 1 working day. There is no universal reporting requirement for LTBI. Some jurisdictions require reporting young children to the LHD, and some require reporting only clusters of cases. Some areas will not accept reporting of LTBI cases and request that the pediatric provider try to identify potential source cases if possible.
There are currently 4 options for treating LTBI in children. The 4 LTBI regimens have equal efficacy, and I encourage providers and health departments to use the regimen that they can afford, with a preference for better adherence in the short course regimens. The first and generally preferred LTBI regimen is now 4 months of daily rifampin. This has been an option for adults for a number of years, and more recently data has been published that rifampin is as effective as INH for LTBI treatment for children. The drug is actually well tolerated once kids get used to the red capsule and the red urine that results. Rifampin seems to have fewer side effects than INH, and the 4-month course improves adherence. Rifampin comes as a 150 and 300 milligram capsule. Some pharmacies will compound a liquid rifampin, which works well for most children. For some families, it works better to jiggle open the capsule and layer the powder into some soft food or a small amount of liquid each day. Older kids can be taught to swallow the capsule whole. Rifampin interacts with many other medications, usually causing more rapid metabolism of the other drug. You should review the child's home med list and advise them to alert any other provider who might prescribe new medications about the rifampin. The second option is a 12-week course of once-weekly doses of isoniazid and rifapentine, known as 3HP. This is a very exciting regimen with good adherence and efficacy, and would be the preferred treatment regimen, except that the rifapentine is expensive, not consistently covered by insurance, and has been intermittently in short supply for the last few years. Since the meds are given just once a week, there's no room for missed doses, and each dose should be given with some sort of support or with directly observed therapy. The studies were done in children down to 2 years of age, and there are weight-based doses found in the resource section. Like rifampin, rifapentine interacts with other medicines, and the home med list should be checked for drug interactions with rifapentine. The third LTBI regimen is also 3 months in duration, but the medicine is given every day. Isoniazid and rifampin are given in the usual doses, and these are listed on the slide. This regimen has been given in the United Kingdom for many years with good success and is generally well tolerated. Vitamin B6 should be prescribed for children taking isoniazid who are exclusively breastfed, or who have milk and meat deficient diets, or living with HIV or symptoms of peripheral neuropathy. The fourth option for treating LTBI in children is the traditional regimen of 9 months or 270 doses of isoniazid, or INH. If the family manages to remember to give the dose every day, the course will be done in 9 months. More realistically, they'll miss a dose here and there and will strive to finish the 270 doses within a 12-month period. Again, we are encouraging providers to utilize the shorter LTBI regimens as they have improved adherence. Use the regimen that your practice or health department can afford, with a preference for better adherence in the shorter regimens.
The hardest thing about treating for LTBI is getting the patient to finish all the doses. Here are a few suggestions. Explain the benefit of treatment and the dire consequences if the child were to activate the TB. It's hard to take medicine for a silent process. If using INH, use tablets rather than the liquid product to avoid abdominal pain and diarrhea. Warn the family that the child may feel a little icky for a week or 2. This is normal and can be minimized by giving the drug with a snack and/or at bedtime. Provide a calendar and stickers. Each time the child takes the med, he or she gets to put a sticker on the calendar. Bring the child back for monthly visits to ensure adherence and to monitor for toxicity. Don't make the family wait in long lines for these visits. Arrange for this to be a very quick nurse visit. The resources section has some sample forms that allow for any provider to monitor for toxicity. For self-administered INH or rifampin regimens, Only dispense a 1-month supply at a time, no refills. When the family comes back, give them another bottle or prescription or call the pharmacy to give one refill. Try to provide a little toy or incentive to keep the child engaged, or offer an incentive at the end of therapy, such as movie tickets, a fast food voucher, or a toy.
Many adults and children feel unwell when they start taking meds for TB or LTBI. We encourage the kids to take the drugs with a little bit of food. The pharmacists tell people to take the meds on an empty stomach, but this is not necessary. A big fatty meal will impair absorption, but a small meal or snack is fine. Taking the meds at bedtime also helps some kids. Kids generally feel completely back to baseline within a couple of weeks, but some adults continue to feel lousy. Some people get a mild maculopapular rash. It's important to distinguish these rashes from allergic rashes with urticaria, swelling, airway compromise, etc. If there are no features of allergies, kids with mild, nonspecific rashes can be pretreated with diphenhydramine, whose brand name is Benadryl, and the treatment continued. Itchiness with or without rash is often well treated with cetirizine, whose brand name is Zyrtec. If your patient has allergy with true urticaria, facial or airway swelling, anaphylaxis, etc., do not continue the medications. Talk to a pediatric TB specialist regarding next steps. Some children will develop peripheral neuropathy or other CNS side effects like headache or visual change due to INH. This is uncommon compared to adults and is not necessary to give all kids vitamin B6, also known as pyridoxine, to prevent the side effects. However, babies who are exclusively breastfeeding, any child who does not have milk or meat in their diet, children with HIV, and children who develop symptoms that might be caused by isoniazid should receive supplementation with vitamin B6. The dose is found on a later slide. TB medications can cause many other side effects, all of which are very uncommon in children. One of the most severe toxicities is a systemic and widespread dermatologic reaction attributed to rifampin. If the child has unexplained fever, especially with expanding rash and unwellness, hold the meds and consult a specialist. Some of these children will need to be hospitalized. We'll talk more about hepatotoxicity on the next slide. Since INH can cause hepatotoxicity more often in adults, people used to routinely document baseline and serial liver function tests. Liver toxicity is not common in healthy children, though many children and adults develop mild, asymptomatic, and transient elevation in their liver transaminases. We no longer draw blood for the vast majority of children being treated for LTBI. Only children with underlying liver disease, taking other hepatotoxic meds, or with symptoms of hepatotoxicity should undergo liver function testing. Both rifampin and INH can rarely cause hepatotoxicity, even in children. The earliest symptoms are anorexia, malaise, abdominal pain, and vomiting. And rifampin can also cause an asymptomatic jaundice. Lots of kids get some of these symptoms with a mild viral illness, but make sure the family is aware and knows to call you if they notice these things for more than a few days. They should call immediately if they notice jaundice, usually observed in the conjunctiva first. Empower the family to hold the meds if they notice a problem for a few days, but ideally you will draw blood for liver function tests shortly thereafter. If you wait more than a few days off meds, the abnormalities normalize and it's hard to sort out. Talk to a peds TB specialist if you are worried about hepatotoxicity or the child has abnormal labs. Some elevation of the transaminases is tolerable and expected. The good news is that even if the child develops true liver toxicity and the meds are stopped in a timely fashion, it is essentially always reversible. Rifampin and rifapentine interact with many other medications, primarily by inducing cytochrome P450 metabolism, decreasing the effectiveness of the other meds. The most common profound drug interactions are with oral contraceptives, warfarin, some HIV, antiviral therapies, immunosuppressants, some antifungals, and GERD medicines. Pharmacists often check for drug interactions when they know about the patient's whole med list. And this Curry Center resource mentioned on the slide is a great resource for outpatient providers. Fortunately, most children do not take other medicines, but this risk must be taken into account when using rifampin.
It is no longer routine practice to supplement with vitamin B6, also known as pyridoxine. Exclusively breastfed children, malnourished children, children with HIV disease, and children with symptoms of peripheral neuropathy should receive vitamin B6. The table shows my suggested doses. In summary, the most difficult thing about LTBI treatment is getting the child to take all the doses and getting the family to follow through. Make it as easy for the family as possible by letting them know what to expect, teaching them good tricks for dosing their child, and providing them with incentives for their child to adhere to treatment. Most importantly, make sure they understand the symptoms of drug toxicity. Monthly visits are important, but they should be very quick and do not necessarily require a physician's attention.